Well, welcome back. This set of lectures is really going to be about blood pressure, the values that we use kind of as a measurement of overall health of the heart and the circulatory system, and um, and then some complications that are associated with it, and kind of how we calculate some of these things and what the values mean. Um, for those of you who might be going into the nursing field, you'll be taking some of these values, and you should know what the actual value is that you're measuring. Okay, so the blood pressure itself is the amount of force that's exerted on blood vessels. Now, normally when we're talking about blood pressure, we're talking about the force that's associated on arteries. Okay, so it's the force that is coming from the heart and it's being exerted on the arteries that are leaving the heart. And we already kind of talked about this with, pressure receptors that are occurring in the aorta, etc., that will stimulate the medulla oblongata to control vasoconstriction, vasorelaxation, and we'll come back and we'll talk a little bit more about how that works in a little bit. Okay? But blood pressure in general is the force that's needed to circulate the blood at least to the capillaries. Okay, and we'll talk about how that works. Okay, so as blood moves away from the heart, you might expect, and it does, the pressure lowers. Okay, so the further away you get away from the heart, the lower the blood pressure is. And so again, pressure in this case is just the amount of force that's needed to push the blood out of the heart and into the arteries that are traveling throughout the body. So normally what we're talking about is arterial blood pressure. Okay, so that's what we're normally measuring is the pressure in the arteries. Okay, and so how that works is blood pressure rises when ventricles contract, okay, which is pretty intuitive. If the ventricle is contracting and forcing blood out, that's going to increase the blood pressure. And then when that ventricle relaxes and less blood is flowing out, the pressure should go down, so it will typically fall. And there are two measurements for this: systolic pressure, or SP, diastolic pressure, or DP. Systolic is the maximum pressure when the ventricle contracts, okay? And diastolic is the minimum pressure that remains after that contraction. Okay, so we typically write it as systolic over diastolic, or in many cases for healthy individuals, about 120 over 80. Okay, and so 120 is the millimeters of mercury needed to force the blood out, okay, during a ventricle contraction. And 80 is the millimeters of mercury that remains after the contraction has occurred. Okay. That can be determined by Korsakoff's sound, as many of you who have heard this in lab or used a blood pressure cuff with a stethoscope, you can pick this up. If you haven't and you want to hear the sound, you can click on this link. If I click on this link, it'll end the video. So we'll just move on. From that blood pressure, that systolic and diastolic pressure, we can get an idea of other values that might tell us a little bit something else about the heart. Okay, the functionality of the heart. How's it doing? Okay, one is the pulse pressure. Okay, and this is the difference between the systolic and diastolic blood pressure. Okay, so the pulse pressure will tell you basically how much, or what's the difference between the amount of force needed to push blood out of the heart and how much force or pressure is remaining. Okay? If the amount of force that's remaining is really high, okay, this can tell you something about the valves of the heart. Maybe they're not functioning correctly. Okay? From that pulse pressure, simple, just SP minus DP. Okay? From that, though, we can get another measurement, and that's a MAP, or the mean arterial pressure. This is important because this can be compared across tables, and normally we're comparing it as an average. Okay, so an individual maybe of that height, that mass, and that age, maybe this is what we'd normally expect. Okay, and if their mean arterial pressure deviates from that, then we might be able to say, well, what's going on? Why? Why is it deviating? Do you have high cholesterol that might be causing vasoconstriction? Do you have, poor heart function? Maybe your ventricles aren't firing correctly. Lots of different things that could be associated with this. Okay, to calculate that, it's fairly easy. 2 times your diastolic pressure and add that to the systolic pressure and then divide it by 3. Again, normally this is used to just compare individuals' maps to kind of a table of averages, or maybe you've done treatments. Maybe the individual needs to be on blood thinners because maybe they do have high cholesterol. Okay? And you take a MAP value at the beginning before you put them on blood thinners, and then you give them blood thinners and you take it after a while and see what the MAP value might be. It's a way to kind of look at that average amount of pressure that's in the system. Okay, just kind of this graph is just showing you the amount of pressure that's in the system and how it decreases a great amount as you move away from the left ventricle. So that left ventricle, right as it dumps into the aorta, okay, the highest point, let's say the highest point for this individual was 120. Okay, that's that during that contraction, the individual had a pressure of 120 millimeters of mercury. Okay, and then after that contraction, it dropped to 80. Okay, so that's what's left. But either way, the systolic or diastolic pressure greatly decreases as you get away from the left ventricle. When you get into the capillaries, so when you're out of the arteries and you're in that connection between arterioles and venules, okay, when you get there, the pressure is really low. Okay, 20 millimeters of mercury. By the time you get into your large veins, it's almost non-existent. Okay, so maybe 5 millimeters of mercury. And we'll come back and we'll talk about what our body does to be able to then take this blood from these small veins and large veins in the vena cava and get it back to the heart. It's not due to the blood pressure. It's not due to the pressure that's generated in the heart. A little bit, as you can see, it doesn't go completely to zero. A little bit of the pressure remains, but not enough to force that blood back to the heart. And we'll come back and talk about what's doing that. All right, other values that are needed and useful when we are talking about functionality of the cardiac system. Okay. One thing that we can calculate is the stroke volume, or the amount of blood that enters the artery with each contraction of the ventricle. Okay. Now, there's this magic number that we often use, 1.85, and we times our pulse pressure by 1.85, and that'll give us our stroke volume. We'll come back and talk about where that 1.85 comes from. Okay, but under normal circumstances for normal individuals, that maybe individuals that don't have a heart condition, 1.85 is the constant that we often use, and we'll look at that here in a second. Okay, excuse me. The cardiac output, we use the stroke volume. Okay, so how much blood is entering the artery, so how much blood is being pumped from the ventricle out. Okay, we use that along with the heart rate. Okay, so how fast is the heart beating? Okay, to calculate our cardiac output. That should make sense, right? The faster your heart beats, the more blood that's being pumped out, the more blood that's being pushed out. Okay, the greater the volume, the more blood that's being pushed out, which is your cardiac output. Cardiac output is how much blood is being pumped per minute. Okay, and that can increase by both. You change your heart rate, it can increase your cardiac output, or you change your stroke volume, how much blood fill and movement would also increase your cardiac output, all of which can change your blood pressure. So a decrease or an increase can change your blood pressure, and we'll come back and talk about blood pressure here in a little bit. Another way that you can alter cardiac output or just alter blood pressure or any of the other values is the peripheral resistance, or the PR. Okay? This is the amount of friction that occurs in the blood vessels. So this is basically related to the diameter of, in most cases, of the arteries, okay, or arterials. Okay? So the less the diameter, so the more constricted it is, the greater the resistance might be. Okay? And so often we're actually after the total peripheral resistance. Maybe we're interested in peripheral resistance of a certain artery. Maybe we're interested in the peripheral resistance of the aorta. Okay? But we'd have to know values directly related to the aorta. But if we know the total peripheral resistance, it can give us an idea of what's going on. Okay, so if you take your map and divide it by your cardiac output, it'll give you the total peripheral resistance. These values can then be compared to individuals that might have vasoconstriction going on because of high cholesterol. And vasodilation may be related to some hormones that deficiency that might be going on, or just the ability for the individual to dilate based on a response from the medulla oblongata, okay, which we'll come back and talk about. Okay, your blood pressure, it results in increased often to overcome the peripheral resistance. Okay, the more peripheral resistance you have, the more friction you have in the blood vessels, the greater the blood pressure has to be to overcome that friction. That should make sense, right? If you're driving with a flat tire, the more gas you're going to have to put in, and the more, or electricity, power, whatever it might be, you're going to have to supply to move at the same rate. Okay, because the greater the friction that is going to happen. It's the same thing that's going on here. Okay, the greater the friction in the blood vessel, the greater the blood pressure has to be. Okay, there's lots of ways at which we can change the friction. Okay, and that friction could be due to vasoconstriction. Okay, so the vasoconstriction could be due to lots of things. Could be due to high cholesterol, so you've got a plaque buildup. It could be due to cold temperatures. Okay, this is why often individuals who are elderly fare a lot better in warm environments. Okay, they move better. Their blood flows better, their blood pressure goes down when they move to warmer environments because they have less vasoconstriction going on, and their arteries tend to dilate a little more because it's warm out, and so you often have a little less of that constriction. Okay? Lots of things going on, but again, directly related. Okay, blood pressure is directly related to the resistance, and we'll talk more about how that's changed and what can be altered to deal with that. Okay, another way at which your blood pressure can go up or down is based on the viscosity of your blood. Okay? Viscosity of your blood is the fluidity of your blood. So how well does it flow? Okay? If you have lots of large molecules, lots of glucose, lots of plasma proteins, lots of red blood cells and white blood cells in your blood, the viscosity of your blood is going to be thicker or slower. So the fluidity is going to decrease. Okay? And so individuals who are type 2 diabetic, typically, they might have really high blood sugar levels. Right? Their viscosity of their blood is poor. So it doesn't flow as well. There's a lot of sugar molecules in that blood's plasma, and it doesn't allow it to flow through the system very well. Okay, so the greater the resistance to flow, or the viscosity, the greater the force, so that's the greater the blood pressure needed to transport that blood. Okay, and so there's a direct relationship. You increase the resistance, okay, to flow, whether that be constriction of the blood vessel, increase in plasma proteins, okay, whatever it might be, you're going to have to increase the force to move that item, move that blood. Okay? And so often, we'll combat a lot of these things with giving individuals blood thinners. Okay, so if individuals are on blood thinners, it's trying to increase the viscosity. Okay, so it's trying to decrease the viscosity. Okay, so it's trying to allow the blood to flow better, easier. Okay, and so you're decreasing viscosity. Viscosity is the stickiness or the resistance to flow. Okay, and so if you're on blood thinners, it should lower the resistance to flow, which lowers the force necessary to transport, which lowers the blood pressure of the individual. Okay, anemia can do this also, right? So if you just have less blood cells in the system, whether you're anemic from red blood cells or maybe you have a condition where you don't have very many white blood cells, okay, you have less cells in the overall blood system, so you have more plasma, which is liquid, and you tend to have a lower viscosity, and then lowers your blood pressure. All right, now back to that stroke volume, that 1.85 magical number. Right? For most people, again, 1.85 is good. Well, I shouldn't say most people. For most healthy adults that don't have heart conditions, that's the value we use. If the individual has a heart condition or believes they have a heart condition, then an echo is normally done, and both these values are calculated. The end diastolic volume, so how much blood is left in the ventricle at the end of distole, okay? And the end systolic or systolic volume, okay? And that's the amount of blood that remains in the ventricle after the end of systole. Now, together, knowing those values will give you the stroke volume. Okay, so how much is left after distole? How much is left after systole? Okay, that gives you the stroke volume. That's where the 1.85 comes in. It is just a known variable that works pretty well in individuals that don't have heart conditions. If you have a heart condition and maybe your myocardial and your left ventricle are deteriorating and dying, then the amount of blood that's left over could be, the volume could be really high, okay? And that 1.85 value is no longer relevant to that individual. But that's really where that value comes in. And that's how another way that you can calculate stroke volume. So you could calculate it either way. And remember, the stroke volume is how much blood is being forced out, okay, at a heartbeat. Okay. Now, there are ways that you can increase that stroke volume, how much volume is being pumped out, and that's called the preload. Okay, so the preload is the mechanical stretch. So the mechanical stretch of the myocardial cells in the ventricle. Okay, that's the preload. If they're stretched out, the greater the stretch, okay, the greater the force of the contraction will be. Okay, that's called the Frank-Stalin law of the heart. Okay, so the greater your preload, the greater the force, okay, of the contraction. Ways at which can affect your end-stallic volume, okay, is you could have a preload that's either great or small, and that's going to affect how much blood remains in the heart after a contraction. Okay. The contractility, so the strength of the contraction. So maybe you have myocardial cells that are dead or damaged. Okay, that could directly affect the systolic volume. Okay, and the afterload. Okay, the force of the ventricle that's needed to open the semilunar valve. Okay, so if we're talking about the left ventricle, it's the force that's needed to open the aortic semilunar valve. Okay, and remember that force it's really going to be related to the pressure that's built up after the left atria leaks blood into the left ventricle. Okay, and then the mitral valve closes off. That pressure will build up, and then once that pressure meets the amount of force needed to open that valve, that's what we call the afterload. Sometimes those valves become dysfunctional, and so your afterload might increase. Or sometimes there might be a blockage, so some of that blood it kind of leaks back, or it creates a need for even a greater afterload to eject the blood. Okay, and we can talk about that in a later date. All right, other ways at which we can control things like blood pressure or the cardiac output. Okay, epinephrine. Okay, so you can get hormonal control of heart rate. Okay, so that's a hormone that's being produced in the adrenal medulla. Okay, and we know that epinephrine is related to kind of fight or flight. And so if you say you see a snake or something like that, that you could get an injection of epinephrine, okay, which is going to increase your heart rate. Okay, if you increase your heart rate, we know that cardiac output, even if your stroke volume stays the same, cardiac output could be increased, and in return is going to increase the blood pressure. Okay. Aldosterone, on the other hand, that's being produced in the zona of glomerulosa, okay, in the adrenal cortex, and that often is regulating the sodium-potassium levels, okay, and most of the time it will lower your blood pressure, okay, and so just different ways at which you can control kind of blood pressure, and there's lots of other ways, okay. One way that we manipulate all the time in modern medicine is the peripheral resistance. Okay? So if we know the diameters of the atrial or arteries are causing resistance, so maybe there's a lot of vasoconstriction, maybe there's a lot of plaque buildup, a lot of cholesterol in the individual, then we need to control and try to increase dilation. Okay, you can do this by thinning the blood so you don't have to dilate, or you can do this by trying to alter the signal from the medulla oblongata to regulate dilation. So it regulates the diameter of the arterioles. And so if you can cause the medulla oblongata to send a signal that says, hey, the vessels are too constricted, we need to dilate, this will open up the diameter and allow more blood flow to go through. Okay, we already talked about this. You have pressure receptors that occur in the arteries, okay, that often sending signals to the medulla oblongata to let them know, is there a great deal of pressure? If there's a great deal of pressure, it's telling the medulla will send a signal to dilate the artery. Okay? If there's no pressure and maybe you get blood leaking back, then maybe it's time to constrict the artery in order to get the resistance to backflow to increase. Okay, so or increase the blood pressure in general. So there are different ways to stimulate, okay, the change in the diameter of the atrials or the atria, and kind of their functionality. All right, now real quick, we're going to kind of talk about that. So we moving from the arteries and atrials, okay, to the veins and venules, and kind of their functionality. Now, I had mentioned this before, okay, the pressure that's generated in the heart, okay, your blood pressure is enough to force the blood from the ventricles, okay, away from the heart, through the arteries, through the atrials, into the capillaries. But then after that, that pressure is not enough in many regions of the body to get the blood back to the heart. Okay, so there's very little pressure that remains at the venous end of the capillaries. Okay, so how do we get it back? Well, in part, okay, we get it back by a few different things. Okay, so first, if it's related to skeletal muscle contraction will force the blood, squeeze the blood back towards the heart. Okay, because the veins have valves, it doesn't allow the blood to flow backwards. It will cause the blood to pool between valves. We'll talk about that here in a second. Okay, but if a muscle contracts in between valves, it will push the blood through the next valve, okay, and that will be moving towards the heart. Okay? Respiratory movement. So blood that's in veins near the respiratory cavities, okay, that will change. That pressure change will force the blood towards the heart. Okay, vasoconstriction in the veins, so often in regions that are associated with smooth muscle, like your digestive tract, etc., the veins that occur in that region, the smooth muscle will contract and force blood back towards the heart. Okay, the one that we often talk about and often are most concerned with is the skeletal muscle contraction. Okay, so individuals that might be having surgery or something like that, where they might be laid up on a table going through the surgery, their muscles, these skeletal muscles are not firing. Okay, and so especially in the leg, okay, that blood is not being forced back to the heart. It will start to pool. So this is why they'll often put pressure cuffs on individuals and stimulate and really kind of act like muscles firing and pushing blood away from the toes back towards the heart. Okay, and again, this just gets back to kind of that 2/3 rule that we talked about before, and that is 2/3 of all your blood volume occurs in your veins. And so they can create what we call a blood reserve or reservoir. And so they can start to pool in regions. And if you don't have that respiratory movement or that vasoconstriction in certain regions or that muscle contraction, okay, that blood can pool in between valves and create damage like varicose veins and things like that. So if you look here, this is just kind of how it works. So if a vein is running next to some skeletal muscle, when relaxed, okay, the valves might be closed. The blood can pool between the two valves. When it contracts, okay, the blood is not flowing backwards in the system. It's one way. It's just towards the heart. Okay, so that valve would open, okay, and the blood would flow into kind of the next section of the vein between two valves. Okay, and so this would happen over and over and over again. Well, if these muscles can't contract, like the individual's having surgery or the individual might not be moving very much, etc., then you get pooling of blood that can occur in between valves. And when that happens enough, it causes the vein to expand, dilate, and then it can cause damage. Okay, and that's where you get varicose veins and things like that occurring. Okay? So clinical applications to all this, well, exercise, diet, tobacco use, all can affect the cardiovascular system. Okay, so remember, your heart is just a muscle, and like any other muscle, if you don't use that muscle, it really will start to deteriorate. It'll start to have less functionality, right? And so cardiovascular aerobic exercise is super important. Okay, not only does it change the muscle mass, okay, so again, it's a muscle. If you keep using it, it will grow in size, it will enlarge, it will become more efficient, it will be better at pumping, okay, its stroke volume will increase, etc. Apart from that, other components of the blood system can change. We've already talked about mitochondria and their role, okay, in metabolism, and the fact that aerobic exercise, the more you use these mitochondria, the better they get, the more mitochondria you stack per cell, okay? Your blood volume can increase, so if your demand is greater for oxygen, okay, you're going to create more erythrocytes, okay, erythropoietin will increase and tell your body that it needs to generate more red blood cells. Okay, in condition with that, hemoglobin, if you're not transferring enough or carrying enough oxygen, hemoglobin concentration per red blood cell will increase. So there's a lot of ways at which aerobic exercise can affect the cardiovascular system. When we talk about things like that have been put out by places like the American Heart Association, they recommend one of two things, or you can do both, whatever. If you're young, then maybe you do both, but they typically tell individuals that they should either do moderate intensity aerobic exercise or vigorous activity, one of the two. So brisk walk, water aerobics, etc. is moderate. Okay, jogging, jump rope, basketball, etc. is vigorous. Now, how much should you do? What heart rate should you get? This is the calculation that they put forth. Okay, and so there's been quite a bit of research that's went into this to kind of validate this. Okay, so if the maximum heart rate is 220, okay, if you subtract your age from 220, so let's say you're 20 years old, you subtract it from 220, so now you're at 200 is the value. That's kind of the maximum heart rate, okay, for the individual of your age, about 200. You should be shooting for a heart rate, okay, that is increased to 70%. Okay, so 70% of 200 is about 140. Okay, that's what your heart rate should be for about 150 minutes a week. Okay, so just 150 minutes a week, get your heart rate to 140 if you're going for the 70%. If you're going for just 50%, okay, get your heart rate to 100 for 150 minutes a week, and that's what the American Heart Association recommends. Okay, if you're going to do vigorous, now you got to go 70 to 85, less amount of time, okay, but more a higher heart rate for that less time that you're going to spend exercising. All right, so lots of other things that can be associated with this. Okay, again, these are recommendations. I'm not here to as a nutritionist or anything like that. Okay, so I'm not telling you to limit salt, sugar, animal fats, etc. These are the recommendations from the Heart Association that they put forth. Okay, so I'm just letting you know what they're going to tell you if you're going into nursing, etc., that you should be telling your patients is this is what they should do. Some of these things, there's really valid information that goes into it, like the reason for doing so. Okay, so limiting sugar, glucose levels, things like that. Okay, that increases the viscosity of your blood, which if you already have high plaque or your arteries are constricted, okay, that is very damaging. Okay, smoking, vaping, etc., it tends to thicken and narrow the blood vessels. Okay, so this is what's going to contribute to constriction of arteries and arterioles, etc. Okay, which means that you increase the chance of having blockage. Not only narrowing the blood vessels, it also increases the stickiness, okay, of the blood. So it changes the blood chemistry and increases the likelihood of clots to form. Okay, so lots of recommendations. Again, I'm not here to condemn or tell individuals what you should do, but there is pretty good evidence behind majority of these things on what they're doing to your body and what they can do for your body. All right, path of circulation. Okay, this is moving right into the respiratory system. So we know that the right ventricle is pumping oxygen, low oxygenated blood into the pulmonary trunk. The pulmonary trunk is then sending it to the right and left pulmonary arteries. Okay, that goes into the lobar branches, and then you just get lots of division into the pulmonary atrials and then the alveoli capillaries. So the connection between the pulmonary atrials and the pulmonary venules is the alveolar capillaries. So these are the cells that are going to hold a lot more oxygen. Okay, and the oxygen will be transferred at this point. Carbon dioxide will be transferred at this point. And then those pulmonary venules are going to send it back via pulmonary veins back into the left atrium. Okay, so blood in the pulmonary arch and atrials is low in oxygen, high in CO2, also typically associated maybe with nitrogen gas in some situations. Okay, but the main two gases that we're interested in is oxygen is low, carbon dioxide is high. Gas exchange happens in the alveolar capillaries, okay, and then blood from in the pulmonary veins is rich in oxygen, low in carbon dioxide. Okay, it doesn't mean it's devoid, okay, of carbon dioxide, or in this case, devoid of oxygen. It just means it's low or rich. So we often say things like deoxygenated or oxygenated. Really, deoxygenated is not really a good technical term because there is still oxygen present in the blood when it makes it to the lungs and transfers that oxygen from the alveolar capillaries. Okay. So that systemic circuit, okay, is really then, so this is the pulmonary circuit. The systemic circuit is then from that left atrium to the left ventricle. You have oxygen-rich blood, okay. The contraction of the left ventricle sends that blood out through the aorta, okay, and so that aorta then goes through all the arteries, all the atrials, okay, all the capillary beds, okay, back through the venules, back through all the veins, and back into the right atrium. Okay. Next lectures, we're going to talk about what's going on specifically in the respiratory system next time.